guys, this is my neuro presentation from last week. It's mostly pharmacology, but there's a couple scattered topics at the beginning. So cavernous sinus syndrome. As you might recall, there is this area of sinus confluence here behind this area of the face called the cavernous sinus, and there's a bunch of other structures running through there as well. So all the nerves that control eye movement, as well as two branches of the trigeminal nerve move through here. And if this area is compressed, it can cause problems with eye movement, problems with sensation to the face, swelling of the eye because the venous drainage of the eye goes through here, and Horner syndrome, which you might recall is a lack of parasympathetics to the face. Lots of things can cause this compression. So you could have a pituitary mass, you could have a meningioma. Commonly tested is a bacterial infection of this danger area of the face, which shares venous drainage with the cavernous sinus. That can cause thrombosis and can cause compression. And the person will have this kind of thing where they can't move this eye at all. And they also have ptosis because they have Horner syndrome. Internuclear ophthalmoplegia, if you see this, especially if it's bilateral, think multiple sclerosis. So basically, this is where the person can't adduct their eye when they try to move laterally in one direction, and the eye that is normal has nystagmus. This is caused by a lesion of the medial longitudinal fasciculus, which is highly myelinated and therefore very susceptible to, for instance, multiple sclerosis. And just a little bit of nomenclature. So a right INO means the right MLF is broken, and the right eye won't adduct when the left eye abducts. Sorry, this should be a B. And the left eye would then have nystagmus. So this is the MLF, the connection between cranial nerve 3 and cranial nerve 6 right here. Okay, and then moving on to pharmacology. So first, anticonvulsants. In general, they slow things down, which makes sense because you're trying to stop seizures. So therefore, they pretty much all cause sedation. But they have lots of other bad side effects, which are more unique to them and are therefore more testable. They are also used to treat other things as well, which is also testable. I would say in general the mechanisms aren't especially interesting or testable, and also the types of epilepsy, with some exceptions, are less important to know. And just a note on the mechanisms, most are sodium channel blockers, which either increase GABA or decrease glutamate. There are some exceptions, which I'll point out. Okay, anticonvulsant. So ethosuximide, you already know, this treats opson seizures. It's a calcium channel blocker. Levetiracetam has this interesting thing where it can make people aggressive or cause other neuropsych symptoms. Topiramate, it is a weak carbonic anhydrase inhibitor, which means that it can cause kidney stones. It also causes weight loss, which is sometimes used for this specific purpose. It's also used for headaches, for instance, migraine prophylaxis or in intracranial idiopathic intracranial hypertension. Lamotrigine, most important thing to know about this is Stevens-Johnson syndrome. So if somebody starts this drug and they get a rash, you stop it immediately because it's likely Stevens-Johnson's until proven otherwise, and you must titrate this slowly to avoid this side effect. It's also used as a mood stabilizer in bipolar disorder, particularly bipolar 2. Valproic acid, just so you know, this has lots of different names, and when I was tested on this on step 1, it wasn't called valproic acid, it was called like divalproate or something. So just so you know, these are all the same thing. You should know that this, in some individuals, can idiopathically cause high ammonia levels due to hepatotoxicity, and this is potentially fatal. Would present as encephalopathy, and so you have to test people's liver enzymes when they're on this drug, as well as ammonia levels. Can cause neural tube defects if it's taken during pregnancy. A lot of people complain of weight gain when they're on this drug. It's also used for a mood stabilizer in bipolar disorder, particularly in people that can no longer tolerate lithium for whatever reason, usually kidney problems. Carbamazepine, first line for trigeminal neuralgia, you should know. Used less often as a mood stabilizer, and it has this interesting side effect where it can cause aplastic anemia. Phenytoin has lots of bad stuff. To know, it causes gingival hyperplasia, which is testable because it's very unique to phenytoin. Can also cause hirsutism, which is too much hair in random places in the body. Can also cause DRESS syndrome, which is drug rash with eosinophilia and systemic symptoms. This is different than Stevens-Johnson syndrome. The systemic symptoms, they're very random. There's like nerve pain. You can get like necrotizing myocarditis. Most people have liver problems, hepatitis. just know that it's associated with phenytoin. It can also cause megaloblastic anemia because it interacts with folate metabolism. So this is a potential biochem tie-in here. Excuse me. And it can also cause fetal Hydantoin syndrome, which is small for gestational age, facial malformations, mental retardation, and cleft lip or palate. It's also used in status epilepticus if benzos fail or if you need to use it for prophylaxis for whatever reason. Okay, lastly, vigabatrin. So this is a structural analog to GABA. It has a vinyl group attached, which then you can see where the name comes from, and it prevents GABA breakdown. It has this interesting side effect where it can cause permanent visual loss. Okay. Benzos and barbs. So I know the slide is busy. I put them both on the same slide because they work kind of similarly, and they have some similar side effects. So they both work on the GABA receptor, which is a chloride channel. And sorry, they both cause CNS and respiratory depression. Barbiturates are worse in this department than benzos, and they both have a concern for abuse. So barbiturates, these are the tails for the most part. They increase the duration of the GABA receptor opening. Okay, and that's as opposed to benzos, which increase the frequency of the GABA receptor opening. And you could be tested on this or pimped on this. You've probably been pimped on it before, I bet. Barbiturates have few uses nowadays. Primidone is used often for essential tremor, and thiopental is used for anesthesia induction. These have lots of interactions with P450, and they've killed people like Marilyn Monroe, I think. So like they're not used a lot anymore. Benzos, the lambs and PAMs, and chloride epoxide. They have many uses, so not chronic anxiety, but panic attacks, insomnia, general anesthesia, status, and alcohol withdrawal. And you can use flumazenil for an acute overdose, but you got to be careful because if you give somebody flumazenil, you're likely to precipitate a seizure because benzos, once you become habituated to them, if you don't have them anymore, you're more likely to have a seizure, just exactly like alcohol withdrawal. If you take away alcohol, you could have a seizure. And so then there's this mnemonic ATOM, which is just to help you remember the benzos that have short half-lives and therefore have more abuse potential. So that would be alprazolam, diazepam, oxazepam, and midazolam. Okay. So Z drugs. These are used for insomnia. They're kind of like benzos because they work at the GABA receptor, but they supposedly have less effect on REM sleep, where benzos decrease REM sleep. These are not supposed to do that. You've probably heard of Zolpidem or Ambien. They make people do weird things in their sleep, and so they're not used that often anymore. Other sleep drugs, so suvorexant is an orexin antagonist. You might recall that people with narcolepsy have decreased orexin in their spinal fluid, and so basically giving somebody an antagonist of orexin, you're giving them narcolepsy to help them sleep. They are therefore contraindicated in narcolepsy, and they're also metabolized in the liver, so you can't give these to people who have liver disease. Ramelteon. So this is a stupid drug. It's a melatonin agonist. You should just give melatonin and not this drug, which is very expensive, but anyway. It works at the suprachiasmatic nucleus. We talked about this last week. This is the part of the brain, of the hypothalamus that basically controls sleep. Okay, triptan. So most commonly sumatriptan, used for migraine and cluster headaches as an abortion medication. It is a serotonin agonist, and therefore, if somebody's on other serotonergic drugs, can precipitate serotonin syndrome. Mechanism of action is vasospasm, and it makes sense because the theory behind migraines is that you have a bunch of dilated blood vessels inside the brain, and that's what's causing the pain. But it's not specific to cerebral blood vessels. It'll also cause vasospasm of like the heart blood vessels, and therefore it can cause angina. So it's contraindicated in coronary artery disease or principal angina. Okay, Parkinson's disease drugs. So most commonly, I would say like the standard of treatment is L-DOPA, levodopa, which can cross the blood-brain barrier and get turned into dopamine. So if you recall, the problem in Parkinson's disease is that there's not enough dopamine in the coming from the substantia nigra. So what you want to do is try to increase that amount of dopamine. And the problem with just giving L-DOPA by mouth is that it'll get broken down in the GI tract. And so what you do is you give it with carbidopa, which inhibits the dopamine breakdown. Okay, so the active ingredient is the levodopa, and the carbidopa just prevents breakdown. You can also give like COMT inhibitors, so tolcapone and tacopone to prevent the breakdown of L-DOPA, but this is through a different enzyme than the carbidopa. Okay, and that's also peripherally. So once L-DOPA crosses the blood-brain barrier, there are other things you can do in the brain as well, other medications you can give. So you can prevent breakdown of dopamine by giving MAO-B inhibitors. So these are siloligine and razagiline, and also you can give central COMT inhibitors, tolcapone. So that was over here as well. You can increase dopamine availability by giving amantadine. I'm not exactly sure what the mechanism there is. And you can also give dopamine agonists like bromocriptine or pramipexole or ropinirole. Pramipexole or ropinirole are more used in Parkinson's disease rather than bromocriptine. All right. Okay, so side effects. Obviously, you're increasing dopamine, so what do you think is going to happen? Potential for hallucinations, arrhythmias in the heart, because if you recall, dopamine acts as acts kind of like epinephrine at the heart, and so you can cause racing heart, etc. Also get movement problems, dyskinesias, with too much dopamine. Okay, so anticholinergics are also used for tremor and rigidity in Parkinson's disease. So, in particular, benztropine and trihexyphenidyl. And I recommend watching, all the sketchy farm videos, but in particular, the autonomic videos, because you'll talk about these drugs in those videos. Okay, so other movement drugs. So tetrabenazine, Huntington's, you might recall, there's too much dopamine just because of the way that the basal ganglia are affected in Huntington's disease. And so tetrabenazine inhibits the reuptake of dopamine and repackaging of dopamine in the neuron. And so then effectively decreases the amount of dopamine that can get released to prevent movement problems. And tetrabenazine only affects movement problems. It doesn't help the neurocognitive problems. But you can give antipsychotics for that as well, for Huntington's, for the more like neuropsych problems. And then ALS has this drug, riluzole, which has been shown to modestly increase survival by decreasing glutamate neurotoxicity. Okay, Alzheimer's disease. So there's one NMDA antagonist, which is memantine, and then acetylcholine esterase inhibitors, donepezil and rivastigmine are also used, and these are symptomatic only. They do not have an effect on survival. All right. Moving on to anesthetics, which I don't know a lot about, admittedly, but I'll try my best. So basically, the inhaled anesthetics, which have decreased solubility in the blood, have rapid induction and recovery because they don't want to stick around in the blood. The drugs that have the inhaled anesthetics that have increased solubility in lipids, they get through the blood-brain barrier more easily, and so they are more potent. And then there's this thing called the MAC, the minimal alveolar concentration, which just describes the amount required to prevent 50% of people from moving in response to a painful stimulus. Okay, inhaled anesthetics, what you should know. So these are the anes, the halothane, etc., and nitrous oxide. So halothane, you should know for test purposes, can cause this weird, severe hepatotoxicity days after treatment. So the way that they're going to present this to you in a step 1 question is somebody goes and has surgery in Mexico or South America or something, because we don't use halothane in the United States anymore, generally. They go down there, they have surgery, and then a few days later they have like fulminant hepatitis, and just their entire liver is necrotizing and dying, caused by halothane. Bad, can kill people. They can also cause malignant hyperthermia. So I'm not going to go over the mechanism of that right now. You can go on over that on your own if you would like. Then IV anesthetics, there's the 5 that you should know if you've taken anesthesia and you know this already. So barbiturates used for induction. Benzos, they're amnestic, so they help people not remember what happened. So they're useful for twilight sedation, for like colonoscopies and stuff like that. Ketamine, so this is a dissociative. It works by blocking NMDA receptors, and it can make people have weird hallucinations and experiences. Propofol, you've probably seen this used, so it's used for anesthesia induction. It's also used in the ICU for people that need to be on vents. It's GABAergic. And then the opioids, in particular fentanyl, obviously used for pain and sedation. I don't know what I meant here. I think you shouldn't use it with other CNS depressants. I don't know. Anyway, local anesthetics. So these are the canes. These are sodium channel blockers. Therefore, potential risk of arrhythmias because you can get off-site sodium channel blockade and then mess with the heart and stuff. So you can give these with local vasoconstrictors to try to prevent them getting from the systemic circulation in the first place. Also to decrease bleeding if you give a vasoconstrictor. And you should know the modalities that you lose first with local anesthetics are pain, temperature, touch, and then pressure. And that's dose dependent. So if you think about it, cocaine is a sodium channel blocker, just like these local anesthetics, and it has been used as a local anesthetic. And so potential side effects, if it gets into the systemic circulation, are CNS excitation, just like cocaine, hypertension, just like cocaine, and then with benzocaine, you can get methemoglobinemia, which is, if you recall, chocolate blood, doesn't carry oxygen very well. Okay, paralytics. So you should know there's depolarizing, which is succinylcholine, activates the acetylcholine receptor until you can't activate it anymore, and then causes paralysis. Their potential side effect with this one is malignant hyperthermia. So then the two things that cause malignant hyperthermia, if you recall, succinylcholine and the inhaled anesthetics. And then there's the non-depolarizing, which are the curiums and curoniums. And these are antagonists at the acetylcholine receptor, and you can give acetylcholine esterase antagonists to reverse. There's not a good way to reverse succinylcholine. Okay, muscle relaxants. So dantrolene, this blocks the ryanodine receptor to prevent calcium release. You can also use it in malignant hyperthermia. Baclofen is a GABAergic drug at the spinal cord, and cyclobenzaprine is essentially acting muscle relaxant. It's very sedating for that reason. Okay, opioids. This is a huge topic. I'm just going to go over the highlights. So with the opioid pain meds, you're targeting the mu opioid receptor, which is therefore mimicking endogenous endorphins. So interesting, opioids, meperidine. You should know this is a serotonin agonist, and if used with other serotonergic drugs, can cause serotonin syndrome. It also causes mydriasis rather than meiosis caused by other opioids. If you recall, a sign of opioid overdose is pinpoint pupils, and meperidine causes the opposite, just so you know. And you could remember that, meperidine, mydriasis, if that helps. Dextromethorphan and codeine, these are both used for cough suppression. You can buy them over the counter. Dextromethorphan, people abuse commonly because it's a hallucinogen. Loperamide, so this does not cross the blood-brain barrier, and it's used for diarrhea. It's Imodium. Then tramadol is a weak opioid agonist, but it also is serotonergic and norepinephrinergic. So there's also a risk of serotonin syndrome with this, and it also decreases your seizure threshold because of the norepinephrine effects. Okay, glaucoma drugs. I highly, highly, highly recommend watching Sketchy for this. Because I think the imagery is really helpful to get a hold of these topics. But anyway, so the general idea with glaucoma is that you want to decrease intraocular pressure to stop pressing on the optic nerve, and you do this by decreasing the amount of aqueous humor. There's multiple ways you can do that. You can decrease the synthesis of aqueous humor, which alpha agonists, beta blockers, and diuretics all do, or you can increase the outflow, which the cholinomimetics and the prostaglandins do. So alpha agonists, basically, so brimonidine. You don't want to use this in closed angle glaucoma because it will dilate the pupil, and that would worsen the closed angle glaucoma. Beta blockers, so timolol most commonly used. Diuretics, so acetazolamide is a carbonic anhydrase inhibitor that would decrease the synthesis of humor. And then pilocarpine and carbachol, these are cholinergic agonists, and they cause contraction of the ciliary muscle, which helps the aqueous humor flow out. And then lastly, bimatoprost is a prostaglandin, which increases outflow. I haven't seen this one mentioned as much, but these ones I would say are more important to know.